cardiology fellowship and residency at MGH. And he was the Romans de Sanctis Clinical Scholar in Cardiology. He graduated from MIT with a degree in chemical engineering, and then went to Oxford for an MPhil and holds a MD and an SM degree from Harvard. Jason's done some of the best work on management or on understanding what drives readmissions in patients with acute myocardial infarction and PCI, something that is highly critical to our collaborative. So it's a great pleasure and a privilege to welcome Jason to the meeting. Jason?
Hi, this is Jason. Can you hear me?
Yes, we can.
Thank you so much for those very kind comments, and thank you for inviting me. It really is a pleasure. I think this whole 6 and 7 months that we've been through have been so surreal in so many ways that we don't have the opportunity to connect at meetings in the same way. So I really do enjoy this opportunity to sort of connect, and I would love to kind of make this a continuous relationship in email, and I'd love to hear what you guys are up to in terms of quality improvement. Can I share my screen? Is that an okay way to do this?
No, if you just click on the screen, Dr. Wasfy, you should have control of my slides.
Okay, I see. Okay, great. These are my disclosures, none of which are particularly relevant to this topic. So, I just kind of talk a little bit about our approach to quality improvement, especially around transitional care in coronary disease, whether it's MI or PCI. We use both qualitative and quantitative institutional data. We spend a lot of time studying the problem before we design quality improvement solutions. Often quality improvement is sort of a bunch of us in a room, and I say, I think we should do this, I think we should do this, and we can't even get started. But I think to really think about the data as driving the quality improvement interventions, both qualitative and quantitative data is really important to us. We use the pressure of external financial incentives, so whether it's government penalties for readmissions or accountable care organizations or whatever, to create incentives internally to sequester funds for important quality needs. And this is important administratively because you can create programs that patients need, but are not the same programs that would necessarily be paid for in traditional fee-for-service medicine. So it's a way to address gaps in care delivery that we perceive. So we studied this problem a lot with PCI. We looked at all the PCI patients that came back to our system, and we found that the plurality of patients, really the biggest category, was low-risk chest discomfort. I know we're clinical cardiologists, not shocking, but actually very few of these patients had stent thromboses or angina. A lot of them had low-risk chest discomfort. And then we also tried to validate prospectively the idea that we could predict their risk of readmission from registry data that we submit to the NCDR. And then we said, could we do even better? We use natural language processing to sort of go into the medical record and really pull out characteristics that were associated with readmission. Again, I know we're all clinicians, it's not shocking. Things like the word anxiety in the chart. I'm not saying a billing code for a generalized anxiety disorder. I'm simply a nurse saying the patient appears anxious. Any word anxiety in the chart, not no anxiety, but would be predictive of readmission over and above the registry variables. And again, not surprising to clinicians, social variables are very prominent, things like homelessness or needing a translator in medical care. And then we looked at the charts and we said they were about half preventable. And that's not a gold standard. That's sort of Monday morning quarterbacking. It's, doctors going through the chart and saying these appear preventable. So it was sort of hypothesis generating. You can't prove they're preventable retroactively, but it started getting us thinking that maybe we could really prevent these readmissions. And then we looked at the data. We looked at the data that we had about low-risk chest discomfort and designed risk prediction tools and patient education, especially around low-risk chest discomfort. And there were really two pillars over and above that. Mandatory follow-up. No matter what, even if the doctor didn't have space, we created an NP-based clinic where patients would be routinely seen within 2 weeks, even if the doctor's schedule was full. And then we also had a nurse practitioner-based electronic a notification system where they would go to the emergency department when the patients did come back. We think that cardiology involvement earlier in the emergency department could sort of snuff out some of this low-risk chest discomfort. So, and what we found is that we were able to increase with these new protocols, we were able to increase the follow-up in our clinics with these standard protocols and these standard clinics. And then we also deployed these education tools, sort of thinking to a patient about chest discomfort. You know, having an MI or PCI is a really scary thing. And so there's a lot of like, oh, is this angina or is this not angina? You know, on one hand, it is a life-threatening thing, but there's a lot of anxiety around it too. And sometimes non-anginal symptoms can be very prominent. So sort of to help patients distinguish between different kinds of chest discomfort, we developed new protocols in the emergency department. We did not want low-risk chest discomfort to just simply be readmitted to the cardiology service simply because the patient had a stent recently. So we wanted, we didn't want them to be discharged necessarily, but we wanted cardiologists involved in the decisions up front. We thought that was a very important part of our protocol. And this is how it would practically look. Like if a patient was readmitted, the nurse practitioner would go see the patient, but the primary cardiologist would be involved. So we really would kind of coordinate among the whole care team, trying to get people involved. And then what we found from our initial data, and these were very preliminary data for reasons that I'll go into, is that the readmission rate for PCI seemed to fall. And that's not perfect, right? Because we weren't really having a reference group. We weren't detecting readmissions to other hospitals. That's an important source of readmissions. So we linked our data to the State Department of Public Health and showed that even relative to readmissions going down elsewhere in the state, there was a lot going on, more radial access, more, clopidogrel was being replaced by ticagrelor. There was a lot of things going on in the system. But even as a reference group looking at other hospitals in the state, our readmission rate seemed to be going down faster. So that really was a sort of encouraging sign, at least initially. The problem is in our Medicare penalties, we still found that we had a relatively high, it wasn't very high, but certainly not as good as we thought we were doing for PCI. So for acute MI is not the same as PCI. Some patients have acute MI without PCI. Some people should have PCI, the other way around. So what we did is we actually went through qualitative research, all the patients that were readmitted and included in the Medicare penalty. Medicare actually sends all hospitals the list. You can look at them in August if you want. You get the list of patients. And we found that a lot of these patients never saw the cath lab. A lot of these patients were too high risk for interventions. This is an older, more complex population. A lot of these patients had type 2 MI where the indications for revascularization is not clear. And a lot of these patients actually declined interventions when they were offered them. So we changed the algorithms that all these programs were using to use CMS-aligned billing codes as opposed to the cath lab. We were focusing too much on processes for patients coming through the cath lab, and it wasn't the patients who needed our intervention. So we shifted. I mean, this is something that our group has kind of spoken on a lot. A lot of patients included in the penalty are patients that don't have, they're not 50-year-olds with sort of classic MI and one vessel disease and sort of go home. A lot of it is with sort of type 2 MI and more complex presentations in older patients. So we didn't know, could we also have the same success for MI? And then we wanted to address some of these statistical issues, making sure that we had control groups, maybe making sure that we detected readmissions outside our hospital. And so this sort of brings to sort of what are the how do you look at AMI readmission? The problem is just showing something went down isn't enough. There could be statistical noise. The samples might be too small to show a difference. There's secular effects. That's why I talk about ticagrelor and radial access. Your program is not necessarily what's decreasing the readmission rate just because readmission rates are going down. These are other things going on in healthcare. The doctors are getting better, the meds are getting better, that sort of thing. And you may have case mix changes. So we tried to do, we tried to use statistical techniques that would address some of these things, in addition to detecting what's so hard to do in readmission quality improvement is just detecting readmissions outside your hospital. It's something that hospitals almost never have real-time data to inform. And this is what I kind of talk about with statistical process control charts. These are charts that are typically used in quality improvement, but they don't account for changing case mix, secular trend, or things like autocorrelation changes in the season. For example, readmissions may go up in the winter. So if you compare the summer to the winter in a short-term analysis, that's not necessarily showing that the program actually caused the reduction in readmissions that you're trying to see. So that's why we use these sort of these statistical techniques like interrupted time series. And so what we did when we expanded the program to all patients with MI, not only those who got PCI, is that we performed segmented linear regression as a form of these models, adjusting for secular trend, again, getting at this issue, maybe things are just getting better without our program. We want to know that our program actually was the thing that made the difference. And looked at things like variables, case mix variables, things like age, diabetes, maybe the patient population is changing. We also did sensitivity analyses. We have data. It's really hard, again, to know readmissions outside your hospital, but we have data about patients in accountable care organizations because the insurance companies send us the claims. So we used sensitivity analyses within these populations and within populations like the Mass General primary care population. These are patients we know get a lot of care in our system. So just to really make sure that our program was working. And what we found, and this was important with the interrupted time series models, they can distinguish between level changes, so an immediate decrease, or trend changes, like a change in slope. And what we found is that when you were able to disentangle those effects, it changed the slope, the level of readmission, but not the slope. So it did provide some evidence that our program was working. And there has been a lot, this is primarily in the heart failure literature, and I don't want to get too much into this because it's a very controversial area, about whether some readmission reduction programs have increased mortality. Long story short is we don't think they do actually. And if anything, this has been raised for heart failure, not for acute MI. But just as a matter of precaution, we wanted to make sure that patients weren't being hurt if they were being turned away, for example, from hospital admission. So we looked at mortality as well, and we found that our program actually was associated with decreasing mortality. So really pretty encouraging, kind of exciting data, simply giving cardiology patients better access to our clinics and cardiology consultation expertise in the ED seemed to be associated with a reduction in both readmission and mortality. And this is what it looks like. It's a reduction in the level, although not the slope, of the readmission rate, which is what you'd expect from a program that was kind of implemented all of a sudden. And so this is how the finances work. Just I'm a hospital administrator as well as a researcher, so I get in the nitty-gritty of the dollars. And so what happens is that basically we have $8 million, more than $8 million at risk from Medicare penalties. We actually get the vast majority of it back. But for acute MI, our program was associated with a reduction of almost $350,000 in the Medicare penalty. So that makes my job a lot easier as an administrator because I can go to the hospital. The penalty is assessed to the hospital, not the cardiologist. So we go to the hospital and say, hey, our program is associated with this reduction in your penalty, and we've done all these analyses to prove it. So is it okay if you continue funding the salaries of the nurse practitioners? It's a really nice story because it's budget neutral, so it's a much easier conversation in terms of hospital administration. And we're doing things that help people. Again, we see a decrease in mortality for these patients in addition to the readmission rate. So we really do think that we're, it took us a while. We had to do a lot of analysis and thinking about the right approach. But in the end, we're really happy because we think that we reduced both mortality and readmission for the patients in a way that was budget neutral and sort of easy to justify in terms of the resources. So I think, from our experience, I think what I would first say, I loved hearing that patient presentation. I think it's always, even as someone who thinks about this a lot, it's always humbling to hear, how the patient perspective, or I don't know, for example, when I talk to my parents who receive care, in Washington, I get them on the phone and it's not entirely clear what happened in the doctor's office. We underestimate the extent to which there's confusion in our patients after they leave our care. So sort of really being clear about defining the populations, acute MI and PCI. So if you want to reduce readmission after AMI, it's not necessarily true that cath lab-based interventions will, those are important, but they're not the whole population that are affected. Detecting these non-index readmissions, sort of understanding where your patients are getting readmitted outside the hospital. Really thinking about rigorous statistical methods to adjust for secular trend and case mix and some of the things that we've discussed. And balance measures, especially when you're decreasing utilization, to really check for unintended effects. So again, thank you. I'm delighted to be here. I guess I'd rather be there with you, but happy to connect in this format, and really appreciate your interest in my work, and would love to take any questions if you have time, or follow-up emails or anything that I can do to help. And I'm eager to see what you guys are up to.
So thank you so much, Jason, for sharing those remarkable results. And what I find intriguing is, just like at a very simple level, two very key but simple interventions. One is getting the patient early to follow-up, and second is a patient that shows up in the ER gets seen by a cardiologist. A cardiologist is contacted before the patient gets admitted, right? So those two seem to be the most important interventions. Did I capture the summary of your key intervention?
Yeah, that's exactly correct. I mean, it's for all the things that we had to think through or potentially consider, some of the sort of fancy risk prediction, and it really was just the access to the cardiology care. To really have excellent, some of the patient education was around making sure they knew how to get in touch with us quickly in the outpatient setting, but the follow-up in 2 weeks, making sure they had slots in the schedule, and the NP-based auto notifications, and the NP was followed by a cardiologist. So just early deployment of cardiology expertise. It's just, if someone says that they have 1 second of fleeting chest pain at rest, but not with, exertion, I'm able to say, don't worry about this, much easier than an emergency department doctor who has 30 other patients and is dealing with traumas and stuff. So cardiology expertise deploying to the point of care was very important.
Thank you so much, Jason. I'll welcome our colleagues if they have any questions or would like to make an observation. So
Hitinder, this is Qureshi. Can I ask a question?
Of course, please.
So a couple of things, great presentation and good results. Thank you. So is there only one practice? I mean, who do you call if there are multiple practices? That's one. And second, how is it different from like an EOC? And third, were you using high sensitivity troponins in this time period?
Yeah, those are all great questions. So yeah, that was actually part of the issue with the practices, right? So we have about 105 cardiologists. It's a big place. We have an interventional practice, we have an EP practice, we have a non-invasive practice, and we have a fellows clinic. We have a training program. So that was a key intervention, is that a lot of patients would be a ward patient or fellows patient, and then they couldn't get into the fellows clinic until 3 months from now. It's just not okay, right? I mean, the patients deserve to be seen. If you have a heart attack, you want to be seen by the cardiologist earlier than that. And so I think creating this separate clinic that was automatic, and there was sort of automatic rules around scheduling. I mean, certainly if a private cardiologist could see the patient in that time frame, that was totally fine. But for these soft spots in the system, like the fellows clinic, or when they're overloaded, we sort of made sure that they had access. I think you also had a question about troponin. We adopted the 5th generation troponin in 2018. So that was after this period, now that I think about it. And then you had a third question that I just can't remember. I'm sorry.
That was about EOC, like, chest pain center or emergency observation center.
Oh, right. Yes, thank you. Right. So as a practical matter, this isn't research, this is just kind of being a cardiologist, is that, as a practical matter, if someone comes in at 8 p.m., I'm at home with my kids, and, the NPs are gone for the day. And so what we did is we used our ED observation unit as a way to sort of evaluate these patients. But what we wanted to avoid was, we paged the cardiologist at 6, but they were driving home at that point, and so we just admitted them, and so you can see them tomorrow. We use the ED observation unit for low-risk patients as a way to delay until the cardiologist or nurse practitioner team could see the patient. So we did, that was definitely part of it. What we were trying to avoid really is just, so certainly if people, EKG changes or things like that, we went through emergency protocols, but if we didn't want you should come in just because you had a stent last week and this sounds dangerous. That's what we were trying to avoid, and that's how we use the ED observation.
Thank you, Jason. Anyone else would like to ask a question? So, Jason, I hope you can stay with us for the next 35 minutes.
Sure.
We'll have some further discussion, and it'll be helpful to get your perspective on some of those issues that will come up.
My pleasure.
Thank you. So, one of the things we pride ourselves on in BMC2 is data. And the second thing I